Kumar.
May I know your name, sir, please?
Sanjay Kumar.
I think this one is yours, sir.
Yes.
There is the right click. You have to go forward. Right one, this one. Okay? And here is the pointer.
Good morning, persons sitting on the dais, delegates, and my dear friends. Greetings from Kolkata. I am really grateful to be here and to share the dais. My talk is on avian hips and what are the recent advances. So I won't discuss here the pathophysiology of avian. It is very common to us, and in day-to-day practice we used to get avian. I will focus only on the treatment part. So as the name suggests, we all know that it happens due to loss of blood supply. The causes may be plenty, traumatic or atraumatic. More than 20,000 cases comes to the hospital for this pathology, and I think most of the cases go unnoticed because the people doesn't reach hospital with this complaint. So once the treatment is aimed or concerned, plenty of classifications come into our mind. From our medical school, medical days, the one classification which is very famous is Fickett-Arled classification, which is radiological based. As we all know, stage 1, there will be no change in the X-ray. Stage 2, only some cystic changes or lytic changes in the head. And stage 3, it will be there with collapse. And stage 4, where acetabulum and your head of the femur both are involved. Along with this classification, when MRI came, the Steinberger classification and the ARCO classification is the recent one, which tells us about the perfusion and the causes. So friends, the question is how to go with the treatment. The million-dollar question is, we have to remember this X-ray. We have to see whether your head is collapsed or this is non-collapsed and this is collapsed. Okay. The all treatment lies on this, whether we are getting the patient in pre-collapsed scenario or the collapsed head you are getting. Once the head is collapsed, the consensus, the literature is clear about that. We have to replace whatever the things you have tried or it has been tried, ultimately it leads to a replacement. And the results of replacement you can assure and they are predictive. But once the head is not collapsed, then the all problem arises when the patient comes you in the initial stage. So in pre-collapse stage, what are the treatment modalities? Non-weight bearing, biphosphonates, anticoagulants, vasodilators, pulse EM therapy, and hyperbaric oxygen. I will come one by one. And the operative are core decompression, and along with core decompression, mesenchymal cells, growth factors, based therapies, porous tantalum implant, vascularized bone grafts, MPPG, vascularized iliac crest graft, vascularized fibula graft, and different kinds of femoral osteotomy. The restriction of weight bearing, it is in the initial stage when the size, the involvement of the head is less than 15%, and if the lesion is in non-weight bearing zone. So the lesion might heal. Anticoagulation and vasodilators, if started, before irreversible segment collapse may arrest or reverse the ischemic osteonecrosis. But you cannot assure the patient. It is only by trial and error. Enoxaparin therapy can be started, the low molecular weight heparin, 6 milligram subcutaneously for 3 months. With different literatures have different view on this. Arthroscopy can be very helpful. It can facilitate diagnosis, accuracy, and provide an adjunct to application of the traditional techniques. Hyperbaric oxygen-mediated relief of ischemia enhances the fibroblastic and angioblastic activities, thereby diminishing the intraosseous pressure and improved microcirculation, so healing the lesion. Now the stem cell therapy, this is a current concepts. This has some indication or contraindication also. Patient with symptomatic stage 1 or 2 AVN of the femoral head. Patients having bilateral avascular necrosis of hip, where symptomatic and the other hip is 0 and asymptomatic. Patient with large greater than 30 asymptomatic lesions found on MRI. And the contraindication to surgery, patient with stage 3, that means the head has collapsed, and avascular necrosis of the femoral head. Patient with rapidly progressive avascular necrosis, and patient having active or chronic infection. Now the stem cell has been tried with many different things. The stem cell combined with platelet-rich plasma has given a good result. And one thing is culture expanded autologous adipose-derived mesenchymal stem cell. All these treatments, the application of the stem cell or the cell therapy, what we are giving the mesenchymal cells, or the cultured osteoblasts, whatever you give, they don't have the literature support that the disease is getting reversed. The only thing that the replacement, the arthroplasty, is getting delayed. We can have some time. The free vascularized grafts like fibula or the ilia crest have a predictive result, and it is the best among the lot. The efficacy of targeted intraarterial delivery of concentrated autologous bone marrow can be given, and it can be injected directly to the lesion site. Cord decompression, it is one of the most continuously and most widely practiced thing done by average orthopedic surgeon. The clinical efficiency of bone marrow mesenchymal stem cell, as I have already told, and they cannot reverse the disease, but at least we can have some time, 4 or 5 years or 10 years, the surgery, the replacement can be delayed, and this is a good thing. Modified the bone grafting, I have already told. Multiple drilling with the multiple mastic like bone allograft for large osteonecrotic lesions in the femoral head. And the other thing is application of porous tantalum implant after curating the lesion. So the take-home message is, in pre-collapse stage, no procedure is foolproof. It cannot reverse the disease. We are not sure that the disease is reversed. Patient selection, pre-collapse stage, has to be done. The process, the pathology can be delayed with these things, and the best treatment is yet to come. We don't have clear-cut answer on this subject. Only the result of arthroplasty is predictable, but as this disease occurs in the young, the problem lies there. So all the measures has to be taken so that the arthroplasty can be delayed. Thank you.
Thank you, Professor Sanjay. As we are getting late, we would like to felicitate you here, and we will conclude Dr. Professor R.N. Singh, sir. Please, sir, you are honored that our senior patron of Bihar Orthopedic Association is here to felicitate you. सर सर आ जाइए हम लोग का ग्रुप फोटो हो जाएगा हाँ सर सबके साथ thank you very much sir thank you Sanjay. We are concluding this session already. We are very much late. Thank you all the chairpersons, sir, and over to Dr. Ashish.
Good afternoon. So may I start the next session, some newer concepts in joint replacement. So may I please invite Dr. Sudeep sir? Yes. So may I please invite Dr. Sudeep sir, Dr. Vishwendra sir, Dr. Vikram Maskar sir, please. And here we have a change, slight change. If we have Dr. Hemant Sharma here, he can talk first.